And thank you to Andrea as well for inviting us to be here. We are so excited to talk to you about our University of Michigan residency prep courses. For our agenda today, we're going to start out with the why, like why residency prep courses are important, although we are very aware that we are preaching to the choir with this group. We will talk a little bit about our University of Michigan residency prep course structure, and we're going to focus on one of our our favorites, our crown jewels of our residency prep courses, our simulated paging curriculum. And then I'm going to conclude by talking about how important it is to advocate for sufficient resources for your curriculum. So we're going to start with a poll because we want to know who's here. And so I think if I do this, I think you guys can see this now. You guys can see the poll? Okay, great. And you guys can't see what everybody's saying until I end the poll, right? Okay. A little bolus of people responding. Good, good, good. Oh, we have a really nice spread. So if I push end polling and then share results. All right, you guys should be able to see the results now. Great, so about a third of you do not have a course, 20% of you are planning on implementing a course, 20% have implemented for 1 to 2 years, 20% for 2 to 5 years, and then about 13% for greater than 5 years. So great, we have a really nice representation of people at different stages. Great, okay, wonderful. So then next slide. All right, so why residency preparation courses? So ideally, we should have a competency-based continuum between the curriculum of medical school and the expectations of residency. And the analogy I've liked to use in the past is puzzle pieces, especially since many of us have been doing many puzzle pieces. So it seems sometimes like the puzzle pieces that you use for medical school are from a different set than the puzzle pieces that you use for residency. Like the medical school one's a Harry Potter puzzle, and then all of a sudden you have the Hunger Games puzzle for residency, and you can't get those two pieces to fit. Next slide. The analogy that I've liked even more recently is more of a Gordian knot analogy, because as many of you are very well aware, the residency application processes have become so complex, inefficient, they've become such a quagmire that whenever you think about the transition to residency now, if you don't acknowledge the challenges of the residency application process, you're not acknowledging the significant stress that our students are going through when they think about the transition to residency. So this is a really nice diagram from the AMA's Health System Science textbook that shows how we unfortunately have incentivized normative thinking, where the students feel like they really have to focus on grades and step exams to match into their best residency program because of the way that our current structure is in the residency application process. Next slide. When you think about the timeline too, students are finishing up clerkships usually, and they start their final phase of medical school or their final year, and they do some sub-Is in the beginning, perhaps in June, get their application in. And then there's this time for 8 months where in the beginning, the students are kind of glued to their computers because they have to respond to their emails right away. Otherwise, they're going to lose residency application interview spots. They're interviewing. I know that the interview season this year seems to have expanded even longer than usual with the virtual interviews. So I have students right now who are still interviewing into February. And so you have this 8-month time where most students are not able to engage in meaningful clinical experiences. And so what is the significance of that? This is a paper that we published in Academic Medicine a couple of years ago. Dr. Heidemann and I are directors of an assessment that students take at the beginning of their M4 year. And if a student matched at Michigan for residency, they took the same evidence-based medicine and urgent clinical scenarios assessment at the beginning of the M4 year and then took the exact same assessment at the beginning of their M1 year. And you can see this red line that there was a significant decrease in student scores, same students taking the same exam, because there's this time where they're not engaged really in meaningful experiences. And so they're a little rusty. What does that matter? Well, the unfortunate question, yeah, go ahead, thanks. The situation is that the transition to residency is a really stressful educational transition to begin with. And we know that this study that was looking at deaths from ACGME programs, that there is an increased risk of suicide at the transition time because it's such a big change in identity formation and roles and location and supports. So it's not the ideal time for students to start out rusty from not being engaged in experiences. And not only that, next slide, this is the end of their medical school experience is a time when students are so interested in developing patient-centered skills to become the best doctor possible from this purple criterion triangle from the health system science textbook. And we have found that students are very, very motivated in this space. Next slide. This was a paper that we published in the Journal of Internal Medicine, and we asked students, what is the difference between the educational experience when you were a sub-I, which is what we usually think of as the transition to residency curriculum, to the experience that you had in the residency prep course. And so these were students in the internal medicine residency prep course. And so these two quotes I think are very telling. How the sub-I is great for really having you start to think about being an intern, but you're being evaluated the whole time. You're trying to get a letter of rec from that sub-I experience for your application, and you better get an honors, right, on your sub-I, or else that's going to be a mark. And then the second quote on the right shows how this is really a space for synthesizing the material and the content that you've learned before in a safe space for learning in a time that they're motivated. So, and so our goal of our residency prep courses is for our students to be ready on day one of residency.
Thank you. And with that, I will talk a little bit more about our specific University of Michigan residency prep course structure. And hopefully this will help to tell you a little bit more about our course and set the stage for the simulated paging curriculum, which we'll spend most of our time on. My mouse will work. There we go. So at University of Michigan, our residency prep courses are a graduation requirement. So this changed last year, which was a little bit unfortunate because last year was the year COVID hit also. But last year was the year that all students were required to take one of the residency prep courses. And we have roughly 170 students per graduating class. As Matt mentioned in his introduction, we have 6 specialty-specific courses. So they are all their own independent courses that are led by their independent course directors. But there are common themes kind of woven throughout the courses, common curricular threads. And we tend to operate on the longer end of the TTR spectrum, where our courses are either 4 or 8 weeks in duration. So they happen every year in February and March, and in fact, are ongoing right now. Here's a little bit more detail about our courses. So you'll see the 6 different specialty-specific courses here. And in the little circles there, you will see the number of students that are enrolled each year. So you can see internal medicine has 2 because we tend to give this course twice. You'll also see that the procedural-based specialties like procedures, OB-GYN, emergency medicine are all 8 weeks in duration because these courses really spend a lot of time in the sim center answering certain procedures and suturing techniques. And the emergency medicine course also delivers a very robust ultrasound curriculum. And so that's part of the reason that we've chosen to lengthen these courses compared to internal medicine, pediatrics, and family medicine. Each student, as I mentioned, is required to take one of these courses, and we tell them to base their decision to match most what their intern year will match. So for students going into dermatology, neurology, psychiatry, those students would all take an internal medicine course. Whereas if you had a surgical subspecialty or even something like anesthesia, those students would go into the procedures-based course. And as I mentioned, we have a huge team of faculty and staff helping to make these courses run, and Helen's going to talk more about the resources at the end. But you can see for our procedures team, we have Dr. Grace Kim, who's general surgery, and Dr. Matt Wixon, who's anesthesia, helping to lead the course. For OB-GYN, we have Dr. Anita Malone and Dr. Helen Morgan. For emergency medicine, we have Dr. Will Peterson. For internal medicine, we have myself there on the left, and then we have Eric Walford, who's a primary care physician, Mark Colby, who's a hospitalist like me, and Amanda Huey, who's a primary care physician. For pediatrics, we have Dr. Brittany Allen, who's a pediatric hospitalist, and Dr. Jess Feely, who's a general pediatrician. And then for family medicine, we have Dr. Beth Jones and Dr. Chris Orizondo. So a massive team that really helps to make this whole curriculum run. I also put here a sample schedule of what a representative week might look like. I put our internal medicine RPC course website on the bottom that has kind of sample schedules and other curricular materials if anybody is interested in kind of helping to generate ideas. But as you can see, this is a big mix of simulation, interactive didactics, and a lot of time for independent study. We usually have a couple half days per week for independent study, and also just allowing students to do, things relevant for their life, like doctor's appointments, dentist appointments. They often match, but need to find a place to move. It's not completely filled with content. And with COVID, we have transitioned almost all of this this year to the virtual setting, except for the sim sessions, which are still in person. And Helen is always taking a lot of great pictures and documenting our RPCs, which I am incredibly grateful for. So I'll let her talk through what these pictures show.
So this was a photo I took on Friday of our emergency medicine students who were in the sim center. And I think it's really important to talk about how engaged the students are in these courses. The intrinsic motivation levels are so high. I was trying to take a photo of them in the actual room, and they wouldn't even look up at me because they were so engaged in the mock code that they were going through. And I love this photo because you can see one of the emergency medicine faculty who's in the room, who's going to debrief with them after the case in a very obviously safe environment. This next photo shows one of my OB students working with Anita Malone on a low fidelity Varies needle for a laparoscopic surgery. And then this next photo, we have a pretty robust anatomy curriculum where our procedure students do intern level procedures on the freshly embalmed cadavers. And this is a photo from the internal medicine course where they are practicing ultrasounds. And I think it's also really important to emphasize with this next photo how this is a time for students to really engage into professional identity formation. This next photo is pre-COVID, of course, but our pediatric students do a scavenger hunt at Target of different neonatal necessities. And this next photo shows our family medicine students who do an advocacy day every year during our residency prep course in our state capital. So really kind of connecting with the advocacy part of the family medicine specialty.
Great, thank you, Helen. And all of these pictures, if you don't see masks, this was all pre-COVID times, as Helen mentioned. I just feel like I have to say that. All right, so what we're hoping to talk about for a lot of the time is our simulated paging curriculum. This is something that is woven throughout each of the specialty specific courses. And as Helen mentioned, is kind of our crown jewel. It receives the highest ratings of the residence prep course curriculum. Students find it very valuable. So we just wanted to talk about this because we've learned a lot of lessons from it, because we know it adds a lot of value to our course. And we think that this is something that could be adopted in some form or another, either a low fidelity or high fidelity scenario in other courses, especially as you think about planning your course for these upcoming years. So when we think about simulating paging curriculum, first I want to talk a little bit about the why and what gaps we're trying to address with simulated paging before I even go into what our curriculum is. I think when a lot of us think about residency prep courses, we think about consolidating knowledge that's already kind of been taught or learned elsewhere in medical school, or reviewing high yield facts, or mastering kind of more advanced procedural techniques. But I think a lot of us don't always see the residency prep course space as a space to really address some gaps in the undergraduate medical education curriculum. And there have been some well-defined gaps that have been described, and that's what I'm hoping to talk about first. So the three specific gaps that I'll talk about briefly before we go into the curriculum are cross-cover practice, medical emergencies, and interprofessional communication. So starting with cross-cover practice. I first want to just start by defining what cross-cover is, because it's not often a familiar term. So cross-cover is defined as caring for hospitalized patients when the primary team is absent. So after the ACGME about a decade ago, further restricted duty hours, most residency programs have shifted to a night float, day float type model, and residents are constantly being paged all the time about patients that they may not have rounded on or have admitted or not be familiar with. And so that's what we call cross-covering. It's really having to make these important triage decisions and clinical decisions about patients who you may not have ever met. In fact, one study showed that residents are paged an average of 22 times per day, and I've seen in surgical literature that number is even higher, upwards of 57 times per shift, which I find to be incredible. One thing that we did a couple of years ago, me and some of my colleagues, is we surveyed incoming interns at University of Michigan. All of them have come from a wide range of medical schools across the country, and we just asked them if they've had any experience cross-covering, like on a sub-internship or have ever gotten formal training. And most had never really practiced cross-covering before, either in a clinical or simulated setting. Most had no formal training. And unsurprisingly, they were not very confident in their abilities to cross-cover on patients. One of our OBGYN residents, Sarah Bell, also conducted this really interesting survey, surveying residents at University of Michigan again, in the early kind of part of residency, or sorry, that was all residents, it wasn't early interns. But she asked them what skills would have been most important for you to learn prior to beginning internship, and listed about 24 skills. And there have been a lot of needs assessments done in this space, so we're not the first ones to ask residents, like, what do you wish you would have known? But this is one of the few that has been done well after this night float, day float model has been established. And so I just wanted to point out, when we got the results back, there was a pretty decent response rate here. And you'll see that, unsurprisingly, inpatient knowledge and medical emergencies are rated as highly important. But you'll also see the next two things are handoffs and cross-cover care. And this just shows how common discontinuity of care is and transitions of care, and that critical ability to be able to kind of triage these pages and know what to do in these settings. The next gap that I want to talk about a little bit is this concept of medical emergencies. And we graduate students with the expectations that they will be able to perform initial evaluation and management of medical emergencies. For those of schools that are EPA based, you'll know that one of the core and trustable professional activities is the ability to recognize a patient requiring urgent or emergent care, initiating that initial diagnostic and treatment, and also knowing when to seek assistance. And in fact, there was a survey of internal medicine residency program directors that looked at the core EPAs and which ones the program directors found most valuable. And here is a partial list here. And you can see that 93% of program directors felt that this was a very important EPA that incoming interns must or should possess. However, I think that probably most of us here would agree that we often protect our learners from taking care of patients who are unstable or who are decompensating, and with good reason. Even if you're on your sub-internship, if a patient goes into an unstable arrhythmia or has a life-threatening GI bleed or some other urgent scenario, oftentimes the intern or senior resident will rightfully step in and kind of help go down that clinical decision-making path and hopefully debrief with the students afterwards. But students are often protected from being in the hot seat. And there was an interesting study done, published in Academic Medicine in 2014, looking at our fourth-year medical students prepared to manage unstable patients compared to stable patients. And so they had 7 different kind of non-acute patient presentations and 1 very acute patient presentation. And they looked at the percentage of items performed correctly. And I don't think it will surprise you that the students were far less prepared to handle the acute scenario compared to the non-acute scenarios. Lastly, I just wanted to briefly touch on the importance of interprofessional communication. I think that none of us here would argue with this internal medicine program director survey that asked about what are high priority skills for interns. And you can see that communicating with nurse and nurse triage is one of the top high priority skills for incoming interns to have. But this is very difficult to assess and train in the clerkship or post-clerkship setting. So just to summarize, these are sort of the 3 gaps that we're hoping that a simulated paging curriculum can help to address. If you think about medical students, we often expect medical students, or we often protect medical students from cross-cover responsibilities. We often protect them from caring for patients with emergent conditions, and we don't typically formally assess them on interprofessional communication. I use the word often because I know that some schools have found very creative ways to implement this training and assessment, so I don't want to generalize too much. But we also know that as soon as medical students graduate and they get that MD behind their name, many times they're expected to be able to cross-cover on 20 to 30 patients at a time right off the bat. They're likely the first contact for patients with medical emergencies, and they're expected to be able to communicate proficiently to care team members. So there seems to be a disconnect here. And our hope is that residency prep courses and something like a simulated paging curriculum can really help to bridge this gap. Not as a cure-all, but as something that can help sort of ease that transition. So now I want to actually focus on what the simulated paging curriculum actually consists of. And what it is students receive a pack of kind of a sign out of fake patients in the very beginning of their course. And they're told to be on call, and they're told that they will receive pages about these patients throughout the residency prep course. So they might get a page then later in the week saying, you know, this patient has a fever, or maybe they're hypotensive, or they have some other kind of acute medical complaint or acute medical condition. And then they call back, and on the other line is a standardized registered nurse. And the student's instructed to call back the nurse and ask the clinical questions that they would ask as though they were standing in front of the patient. So they might ask more about the history, they might ask the nurse to do a physical exam or order empiric diagnostic evaluation or treatment options. And these standardized registered nurses are very experienced in these cases. We have 2 nurses that work for us, and they each have over a decade of experience delivering simulated pages. And they also work in the hospital in the actual clinical setting, so have a lot of clinical experience as well. And this comes into play when they give feedback to the students afterwards. So the student will kind of walk through the scenario with the nurse, and at the end of the phone call, the nurse will break character and give feedback on clinical decision-making and communication. Each student throughout the residency prep course receives 6 to 8 specialty-specific pages. So even though this paging curriculum is all-encompassing in our courses, the internal medicine students will receive very different paging cases compared to the OB students. And we did not make this up from scratch. We adapted this from existing surgical curriculum that's been published extensively elsewhere. We essentially took their curriculum, modified it extensively, and expanded it to meet the needs of all of the specialties. And the conceptual model behind this curriculum is really that of deliberate practice. Students will talk through evaluation and management of an urgent condition, something that they're kind of put on the spot and they don't have a lot of experience doing prior to this course. And then they will get immediate corrective verbal feedback on clinical decision-making and communication. And they actually get delayed written feedback sent to them as well. And then a gold standard approach is reviewed in class. And also many of these cases are reinforced in other parts of the curriculum, either through didactics or simulation, like mock codes, that type of thing. So really this is a cycle over and over. The students are practicing, they get feedback, gold standard, practice again. And so it's really that deliberate practice and that corrective feedback that drives a lot of the success of our paging curriculum. As I was making this slide, I was at home with my kids, and my son showed me that he was practicing his letters on his whiteboard. He's 4 years old. And as Helen wisely pointed out to me, this is not deliberate practice, because he did not get any corrective feedback in this example. And he is writing most of his letters backwards. So this here is an example of just practice. And this is what happens when you just practice responding to pages or or doing things your intern year, but you don't get that immediate corrective feedback. And so this is how I responded to pages. Maybe I was doing some of them right, but maybe I got everything backwards in residency, you know? So trust me, we have corrected him, but I just thought this was sort of an ironic example to share. And then this might sound all fine and good conceptually. I wanted to share an actual example of one of the cases from our internal medicine curriculum. So you can see here, this is an example of a sign out that a student might receive about a patient. In this case, they get a sign out that there's this 88-year-old man with dementia admitted for placement, and you get a lot of information, as is really common in sign out these days. And then they get a page that he has a pretty high grade fever. So they call the nurse back, and you would hope that they would ask for things like a full set of vitals, symptoms, physical exam, that type of thing. And the nurse has a very extensive script that they are trained in. So they have lots of information for the students if they ask. They have the vitals, the physical exam, information about access. You will notice here that the patient is pretty ill. They're hypotensive to tachypnic. And so we're hoping that the students will recognize in this case that that the patient is in septic shock. The nurse has a whole host of answers about questions a student might ask about symptoms listed as well. And if the student chooses to order diagnostics, in this case, the nurse would give them that information right away. So in not all cases do they get the information right off the bat, but in this case, they would get the information, and you can see here that the patient here is quite ill. So the student in this case is supposed to recognize that this patient is in septic shock due to a community-acquired pneumonia, and they're supposed to know to get blood cultures, bolus fluids, start antibiotics, that type of thing. It's a very involved case, and the point is not to kind of go over the clinical aspect, obviously, but just to show what kind of rubric they're being graded on. So here's an example. They have things that they must do, things that they should do. It's kind of a weighted, predefined scoring rubric. We also have things that they could do that are somewhat neutral, and things that they shouldn't or mustn't do, like unnecessary procedures, for example. So at the end of the case, the nurse will score them on their clinical decision-making. They will get emailed with what their score is, and the nurse will go over the items that they missed. Again, this is a very comprehensive, like gold standard approach. So we do not expect students to get 100% on this by any means. The nurses also assess students on their global communication skills and many different communication domains, and things like assertiveness that are actually pretty difficult for students that they haven't often practiced in their clinical years. Nurses also give free text comments that are later emailed to the students, and they comment on the students' professionalism. In terms of some outcomes of our curriculum, so you can see here, this is from a couple years from our internal medicine course, when we had 5 cases, and the overall clinical decision-making scores trended towards improvement throughout the month. That last case, they sort of dipped down. It happened to be the most difficult case, but overall, students do get better as they practice. You can also see our global communication scores here improve throughout the month as students get more comfortable talking with nurses and talking about urgent scenarios. And we even look at specific communication items. So for example, closed loop communication, which is a really effective technique for interprofessional communication, especially in these types of urgent situations. We show that it did improve throughout the course. That p-value is slightly above 0.05, which was unfortunate, but reassuring that by the end of the course, most of the students were closing the communication loop. We also show that skills like assertiveness and being instructive and directing all improve throughout the course as well. And then the students end up really loving this curriculum. So at the beginning of the month, it's something that they're probably the most nervous about, being on call and answering pages about critical conditions. But by and large, this is the most popular aspect of our course. Here's some quotes, and I'm not going to read them off to you, but I'll just point out a few things. So many students like the breadth of topics that are covered in each course, and many comment that, if I was a medical student going into internal medicine, maybe I did my sub-internship in GI, over a year ago, and maybe I saw a ton of GI bleeding, but I didn't get any of these other common medical scenarios. This quote highlights the value of the nursing feedback. And I like how they say at which sort of seems like an obvious statement at the end, but it's really true if you think about it. In real life, people don't always give feedback on something they didn't like. And as medical educators, I think we can all agree it's really difficult to give negative feedback. But especially in the clinical setting, for other members of the care team, that's incredibly difficult to do for medical students and residents, and especially when there's an inherent power differential there. So this is one of the few times that students are getting really authentic clinical feedback from nursing colleagues just in time before they transfer into the residency phase. And lastly, this quote just highlights how students really do like being in the hot seat. They like being forced to make those quick decisions and then learning from them in a safe environment. That's Jones, who's one of our family medicine course directors, also takes the lead on sending out surveys to our residents after, or surveys to students after they graduate the course and become residents. So she'll send surveys to them a few months into residency and ask them what was the most valuable aspect of the course. And here is a student reflecting that they were cross-covering on a patient with respiratory distress, and it really reminded them of one of the mock pages. So in summary, simulated paging curriculum, it addresses a lot of gaps in undergraduate medical education. We've shown that it improves communication skills and students find it very valuable. So in terms of the lessons that we learned from this, so there's a few. One of them is that I was most surprised by was how important the nurse feedback was for the students. And in fact, this ended up being some of our richest data. So as Helen can attest to, I really like numbers. So I'm like to plug things into Excel and graph them out and follow these numerical scores. So I was surprised when students said, actually, no, it was this less tangible kind of feedback from nurses that ended up being some of the most important. And Helen, I don't know if you want to share that story about that student that you had last year.
Yeah, a couple of years ago, there was a student where the nurses felt like there was a professionalism issue. The student was not answering the pages, and when they were finally able to get a hold of her, she seemed really rushed and really short. And so when I sat down and gave her this information, it was so fascinating because this was a superstar student who had never received negative feedback like this before. And it was really hard for her initially, like she cried. It was a really hard conversation, but then she really thought about, okay, what would happen if this was the way the nurses perceived me on labor and delivery? And we all know what would happen to her on labor and delivery if this is the way the nurses perceived her. They'd haze her. But instead, she was able to reflect and really think about her goals for starting residency and how she would come across to others to be her best self. So really, really kind of powerful feedback.
Thank you. We also learned that resources are incredibly important in order for this curriculum to be delivered successfully. So the pages are very expensive. They're a little more than $18 per page. And last year, just to give you a sense, we sent over 1,000 pages to students. So really important, and Helen's going to touch on this in just a little bit. But going hand in hand with that, it's helpful. It's really helpful to define these curricular gaps ahead of time and then be able to track data and show why your curriculum is so important and why it makes such a big difference, why you need resources. Lastly, we happily realized that this curriculum is one of the few COVID-friendly things that we had last year when everything got turned on its head due to COVID. Luckily, assessing students non-face-to-face on their clinical decision-making and communication skills was one of the few things in our curriculum that did not have to change significantly with COVID. So how could this be adapted to other courses? So I know that we have many people that are still in the early phases of planning their courses. And so there's been a few ways described that other courses have adapted this similarly. One is having, oops, I think somebody is unmuted. One is having students give the cases to one another. So even if you can't hire nurses to do this, you could give students cases and scripts and have them kind of quiz one another. The important thing is having them practice being in the hot seat and sort of giving them that immediate feedback afterwards. And I know that there are some courses out there that do this as part of their course. Another is involving nursing students. So there was a really cool Med-Ed portal article published recently. They have a very similar paging type of training program, but they use master's level nursing students to deliver a lot of the content. And so this would be a very rich source of interprofessional education. For schools that have a robust standardized patient program, I know that some schools hire standardized patients to play the role as nurses, either in in-person settings, but this could also be adapted to paging settings as well. And then lastly, what we consider to be kind of like the gold standard would be to hire standardized registered nurses. And so at our program at Michigan, our nurses are always happy to collaborate with other schools. They currently deliver cases for Boston University School of Medicine, Internal Medicine Boot Camp. And I also put the SIU School of Medicine website up here because they have a very robust surgery paging curriculum that actually predates our curriculum and would be very worthwhile to look into as well. And we actually use some of very similar cases for our procedures course.
Great, thank you. And so I wanted to conclude by talking about resources. We've had several questions already about who are the faculty directors and do they receive protected time. And so I'm definitely going to touch on this because I think this is such a vital, important point, and we wanted to end on this because this is not a space where medical schools in the past have allocated resources, right? There's pre-clerkship resources, there's a lot of clerkship resources, there's some sub-R resources, and then there's the fourth year. And it's been a little bit of a wild west. And so we are very, very fortunate at Michigan that we have had the support from our medical school in developing our courses. Next slide. So as Lauren mentioned, these pages are expensive. So these are the 6 different courses, the number of students, how many pages, and the cost. So last year it was $25,000 to actually cover the cost of the paging curriculum. And then next slide, we also had 2 faculty. So Sam Kempner is one of my partners, OB-GYN partners. And so she has a 10% FTE support to work on the paging curriculum. And Lauren, as she mentioned, is the master of all things spreadsheet related. And so it has been very, very helpful for Lauren as co-director of our residency prep courses to help organize all of this. We have, we are from a school that in the past has had a very good football team, and this football team used to be known for the expression, the team, and we have an amazing team of all of these different faculty. And then if you add Dr. Kempner, it's 1.5 FTE. So each course director has around between 5 and 15% of protected time for the whole year, with most of their time spent during the residency prep courses. But there was quite a bit of time to develop these courses, especially the first year that we were building them. Faculty time is really important, but I cannot emphasize enough how important it is to advocate for staff support as well. So of course, all of these pre-COVID photos of our team, but we have 7 different staff members with 1 program manager who help us to organize our residency prep courses. Lauren and I meet weekly with our program manager. We've been meeting weekly for 2 years now because there are so many different administrative questions that come up throughout the year when you have all of your students going through the courses. We've been very fortunate that even last year, 2020, when COVID hit right in March, and our courses are in February and March, that despite COVID, our courses were very highly evaluated by our students. So you can see on a 5-point Likert scale, all of our courses received very high ratings. And that's some of the pushback that we get sometimes. People say, but students want to be checked out. They want to, they have senioritis. But we have found that if you provide good content, the students are really engaged because they are very motivated. We've been able to really look at impact in many, many different ways. We've been able to publish in Journal of Surgical Education and anatomy journals, Journal of General Medicine, Journal of General Internal Medicine, Journal of Graduate Medical Education, and Clinical Teacher, because this is all new content, because it is a little bit of the Wild West, because this is a curricular space that has not been delved into much in the past. And because our faculty have FTE support, even though the planning for the first year is over, we are very fortunate that we can have faculty working on different components moving forward. So Beth Jones has really been our evaluation guru, and it's so important, I think, to get the feedback from residents once they are residents after they've completed the course, so you can really determine what are the most high impact activities. Anita Malone and Brittany Allen have been working on interprofessional conflict and communication, because we know that is such a challenge for new residents. And then we're really excited about Sam Kempner and Matt Wixon working on updating all of our residency prep courses with diversity, equity, inclusion, because we know that students know that this is such an important part of the transition that has not been focused on in the past, yet will make such a difference for our patients and for our learners as they go through this transition. And so our take-home points, Lauren?
Yes, thank you. So we just wanted to end with a few take-home points. One is that, as you all know, residency prep courses fill such an important educational gap in the medical school to residency transition. And particularly things like simulated paging are novel ways to assess numerous competencies that are not often addressed in UME, including things like medical emergencies, cross-cover care, interprofessional communication. And lastly, if you're going to do this and you're going to do it successfully, you really need to advocate for resources. And I know that can be easier said than done, but they're really essential for the development of residency prep courses. So I also wanted to, whoops, it's not working here. Here is our reference slide. We tried to include the references as they came up on the slide, but here is the full list. And with that being said, we'd love to take questions. We listed our emails here, so feel free to reach out to either of us individually. I also put our internal medicine course website on the bottom there if you're interested in just kind of seeing what else our IM course does. And I'm just opening up the chat here to answer some of the questions that has gone with that. Oh, thank you, Helen, for addressing some of these already.
Great. Do you want to stop sharing so we can see if there are general questions, the additional questions that people have? Oh no, just silence. Oh, great. Lauren, do you want to talk a little bit about the training that the nurses get?
Yeah, so we're fortunate that the nurses have been working with us since our very first prep course was established, and that was the surgery. We called it the surgery boot camp back then. And so they've been delivering these mock pages for over a decade, I think almost 15 years now. And so when a case is created, because we are kind of changing out cases and making new cases all the time. But what we will do is we will first create the medical content, the script, the rubrics. We typically send them to several faculty members first before we even get it to the nurses to look over for content and accuracy and clarity. And then we will send it to the nurses who will kind of read it up, memorize the script. And then what we do is we have them practice delivering the case either to a student, a resident, or somebody who's not as experienced in that area. So for example, I had to practice taking my OBGYN cases, which was terrifying for me. But they practice seeing how we respond, what types of questions we'll ask. And then they both independently grade us on our, independently grade me on my clinical decision-making and communication score. And we try to see how closely they match. So we sort of work our way through the parts that don't match and talk about why. And that's how we try to develop inter-rater reliability. We haven't formally calculated this in a while. I know that back a couple of years ago, this procedures course did calculate inter-rater reliability, but I don't have those numbers.
Great. Lauren, can you put the link to your website in the chat so that people can copy it? And so somebody asked a great question about how many of your students have moved away. That is definitely an issue. That was definitely an issue in 2020 because we made the decision that we wanted in-person sessions. And so we have quite a bit of simulation, in-person suturing. And so we said that students had to come back for the course. And so we kind of messaged this months and months ahead of time so that they knew. And so they've been back, and we've been hearing only positive things. So February and March is when we decided to have our courses. We thought March they were going to be in town for Match Day, back when Match Day was in person. And we strategically decided that February and March would make sense. I know other people have done March or April or May, but that's just how we chose to. Sorry, there was a question here I want to make sure that I addressed. And so our clerkship, our post-clerkship curriculum is 17 months long. And so that I think has helped us to add this because it was something new, of course, because it was an elective in the past that we made required. In terms of the format for students getting feedback, they receive the verbal feedback right after the call when they break roll. And then they get the written comments emailed to them through Lauren's amazing magic through Qualtrics, where it automatically gets sent to them without somebody having to kind of push it to them. Our pre-clerkship curriculum is 13 or 14 months. I think that's correct. 13 or 14 months. In terms of data on success rates, I think that is the magic, right? That we all have to be working towards, because we want to show that it's these investment of these resources is worth it. And so that large survey that Lauren mentioned that Sarah Bell, one of our residents, led, we surveyed all the residents of Michigan, and we did find that students who had participated in a 4-week or longer residency prep course felt more prepared for residency. Now, I know that's feeling prepared for residency is somewhat of a subjective measure, but that's the one data point that we have so far, that they felt more prepared for residency. And these were residents of all years, so HO1 through, fellows included.
I wanted to just address a quick comment that was earlier on. Are there any particular websites, articles, resources that you give to the med students for their learning in preparation for your course? So I will say that before the course starts, we'll typically send out our course website and that type of thing, but we don't really require them to do any pre-reading specifically. But for many of the specific sessions, we will have them do pre-reading ahead so that the session itself can focus more on question and answer or an interactive type of curriculum.
I think that one of the reasons the students love our course so much is that we do provide a good amount of reading that they can do during the course. And many of those students take that and they make a Google folder right away and they download all of it so that it's a nice resource for them. We have the students do chalk talks to each other so that it's a talk that they can give to a medical student if they have 5 minutes of downtime, and they give those chalk talks to each other so they can steal them so that they could then start residency with maybe 10 or 15 chalk talks, or if they have a second with a student. Lauren, there's a comment about the website being restricted.
Oh, I'm sorry. I will fix that. It should be a public website, so sorry about that. I'll fix that right after this meeting ends. I wanted to answer the question about the passing standard for the pages and remediation, because this is very tricky. This is something that one of the challenges of residency prep courses is that they occur so close to the end of medical school that if you do find things that really need to be remediated, that becomes tough because the window of time is quite narrow. That's one of the reasons that the procedural courses are so long. They're 8 weeks, and those last 2 weeks are usually set aside very intentionally for remediation purposes. In terms of the paging cases, some of our courses have started to set standards from a standard setting committee. So in our internal medicine course, we've had a standard setting committee meet and set pass-fail standards for all of the paging cases. And these tend to be quite low because we expect the students to do so much. So they might be like 50 or 60%, but if a student does or below that, then we do have a remediation kind of reflection assignment where students will just have to reflect on some of the things that they learned after going through the debrief and after going through the case. And many students can think of about like 10 or 20 things they would do differently next time. And it's very clear that they understood where their areas of weakness were, and usually they've, kind of, you can see significant improvement as the course goes on. So we have started to do that specifically for the paging curriculum as well. I will also mention that that looks like, I'm just reading the chat more about the website. The website is public, but some of our specific links are only for people at University of Michigan, since they have names, so they're kind of more sensitive information. So the MAC paging curriculum link is one of those.
And that's a great point, Lauren, that somebody asked earlier, can we fail a student? And I haven't found in the past that we've had to fail a student, but having the 2 weeks in our 8-week courses specifically set aside for remediation has been so helpful, because the way that I talk to the students is we want you to feel like you are going to be ready. And if you are scoring very low on our medical knowledge assessments, or if you can't, get your suture under the times that we expect, you probably want to practice and come back. And they have all practiced and come back because they want to start residency on a strong foot. Great. Well, thank you everybody for such wonderful questions. And we're so excited that so many of you were able to join us for this talk. We're happy to chat with anybody afterwards as well. So please send us an email if it'd be helpful to have a conversation.
Yes, thank you everyone.